every time we try to restart it. Okay, so I'm Laura. I am the PA with the Structural Heart team. I work primarily with Dr. Rinaldi and Dr. Downey and Dr. Skipper.
Oh, so you work here?
I do.
Oh,
I
okay.
do. I'm mostly on the outpatient side, working with patients out from there.
Can I see what it looks like?
Oh, yeah.
Okay.
Yep. And the primarily Jeanette and some of the other ACPs that are shared now,
Yeah.
and I think some of them will filter into. But we'll be seeing those patients in the inpatient side. But Dr. Skipper, Dr. Rose, Dr. Shearer, kind of the team, the structural heart team. And like I said, the reason to revisit this is just kind of a change in pathway of mitral valve repair for patients, and also that the Watchman procedure was FDA approved in the end of March. So we'll be ramping up on the volume of patients that we see for that. Presently, they will both stay pretty low volume procedures in that mostly around 6 patients a month for each of those procedures. So it's not something that's on a daily basis. So one of the things that I have appreciated the most since coming into this role is that there are really actually 2 kinds of mitral regurgitation. The type of mitral regurgitation that comes, so primary or degenerative, is when something is structurally wrong with the valve itself. That's a prolapse, that's flail leaflet. So the treatment for that is fix the valve, because that's where the problem comes from. That's in contrast to patients who have, secondary or functional MR. So that type of mitral regurgitation is when the overall heart pumping function is typically reduced. They have had dilation of the heart that's pulling apart the annulus, and in turn the leaflets are no longer coacting and they're getting leaking because of that. So while a repair is doable for those patients, it is probably not going to be the only way to fix their MR, because the underlying source is from something other than just mitral regurgitation. So the reason to know about this is that just factors into how we think about treating these patients down the line. When we typically look at patients for their evaluation, the 2 things that factor most in the decision-making process, or probably 3 things, is their TEE, to show truly what the anatomy is and what the mechanism of their MR is, their heart catheterization, and then the surgical assessment. So we often see these patients in conjunction with Dr. Skipper or one of the other surgeons, and thinking through, is this going to be a surgical patient or somebody who would benefit from percutaneous repair. For the patients who have functional or secondary MR, that's when the heart failure and EP evaluations are particularly helpful and important.
So structural and functional, those are the
Degenerative and functional.
degenerative and functional.
Yeah.
Okay.
So surgeons even have 2 different ways of addressing, from a surgical standpoint, the 2 types of mitral regurgitation. But what we also know is that repair is going to be much better than replacement when anatomically feasible. And that carries into talking about whether we're doing conventional or percutaneous options. This is really just to show kind of the pathway of looking at severe primary degenerative mitral regurgitation based on ACC guidelines. But essentially, somebody who has severe and symptomatic primary MR is going to end up with mitral valve surgery, whether that be conventional or percutaneous. So Abbott is the company who developed the MitraClip system. They first started looking at patients just with degenerative MR and saying anybody, whether you're a high-risk surgical candidate or not, who is going to benefit from this procedure. And what they learned is that it's going to be the high surgical risk patients, because MitraClip a percutaneous mitral valve repair improves quality of life and can reduce heart failure admissions, but does not change the mortality risk for patients with MR. So there's now a Class 2B indication for transcatheter mitral valve repair. And then these are some of the considerations as we're thinking through whether they are a surgical candidate or not. And then you'll just see that that's very different pathway than the patients who have functional MR, where it's really optimizing medical management, treating their underlying coronary disease, getting them a CRT therapy if need be, is really the cornerstone. And if they're still symptomatic, then we consider mitral valve repair or replacement. But what we've actually learned is that annuloplasty in that patient population has a really high risk of recurrence. So a surgeon is also not typically going to be eager to operate on this patient population. And really what we don't have clear evidence that surgery is going to be helpful. We are looking through clinical trials whether percutaneous mitral valve repair has a benefit. And we Sanger participates in COAPT, which is the clinical trial looking at that, where a patient would be randomized to best medical management versus clip therapy. So you may see some of your patients come through on clinical trial protocols, and that would be why. That's just to summarize what we've talked about. Animation. So a large catheter in the range of about 23 French, very large, done transvenous access and crossing the septum. Procedures took probably about 4 hours or so when Dr. Rinaldi first started, in as early as days, and now are in the range of 1 to 2 hours for procedural times. We can put typically between 1 and 3 clips in place, and that's dependent on how satisfied we are with the level of MR reduction with 1 clip versus balancing that between preventing mitral stenosis. So we wouldn't automatically put 3 clips in everybody because that can reduce the orifice size, and we don't want to leave somebody with mitral stenosis that would leave them as symptomatic as they were with their MR. So the device itself is made of cobalt chromium and polyester covering. And it's this thought of leaving them with a 2-opening orifice that reduces the degree of MR.
That we have to, we're not recording. And it's thought that the longevity of the device is probably in the range of 15 years or so. And for the patient population that's receiving the procedure, that is thought to be, for the duration of their life. So the procedure is done under general anesthesia with fluoroscopy, although it's used very minimally through the procedure. I'm really just guiding where the tip of the catheter is. Really, the placement of the device is guided through transesophageal How does it stay
echo.
there? How does the clip stay?
Tension, really. And
Does they sort of open something up and it sort of pushes out?
So think like
Or
a
they're,
closed.
or they're, it's the opposite, I mean,
Yes.
pinching,
Exactly.
sorry.
Exactly. So no need for cardiopulmonary bypass, done transfemorally with venous access and a shorter procedural time though. And the most common risks and complications still are in the range of like 2 to 3% for major complication for the patient. So relatively low risk procedure. It's about 85% of the time effective. So even greater than the actual risk that accompanies the procedure is the possibility that we attempt the procedure and are just maybe not satisfied with the results, or there's something anatomically that's preventing us from completing it. So cardiac tamponade and pericardial effusion are real risks to keep just in the back of your mind. You may think, it would make sense that every patient we're crossing the septum, are they going to end up with a clinically significant ASD, but that is not the case. Most are truly insignificant and end up closing on their own with time. In all of the years Dr. Rinaldi's been doing the procedures, which is like greater than 10 years and 200 so patients, only 2 had clinically significant ASDs, and both of those were repaired percutaneously. While vascular injuries, bleeding are risks, because of the catheter size, the fact that it's venous makes that less likely than you would see with your arterial patients. And some risk of renal insufficiency because contrast was used, but that's pretty minimal. So things to think about if in this pathway is that patients are going to be extubated before they come out of the cath lab. They'll very likely have their radial art line removed as well. Urinary catheter in place. Because of the catheter size, Dr. Rinaldi will leave a figure of 8 suture. He typically removes that on post-op day 1 or post-op day 2. The patient will also come generally with a femstop in place. Most patients, the recommendation will be bed rest until the morning after their procedure and a NUSA of SCDs rather than sub-Q heparin. They will be started on aspirin and Plavix, unless they have a reason to be on Coumadin for their underlying, another reason like atrial fibrillation. And we typically keep Plavix for 2 days. And then in general, patients are here on average 2 days in the hospital too. Most common things that patients complain about immediately post-procedurally, and even like when I'm seeing them at their 1-week follow-up, that they have a sore throat following their TB. The fact that they can get hypotension, and we were talking about this earlier, mostly related to anesthesia effects, not primarily driven because of their MR. So just keeping in mind that we may not be ramping up on their home antihypertensive medications initially, but that's something that's just gradually reintroduced. And for the big picture, we see the patient back at 1 week, 1 month, and 1 year. And the 1 month and 1 year follow-ups are both with the transthoracic echoes, and that's at the anybody who participates in performing this procedure is part of a registry. Those are just guideline registry requirements for patients. Any questions you guys have in taking care of the patients or prior experience?
Pretty good.
Good.
Yeah. I have a question. Do you have any information at the 15-year, or that when they start degrading, what does the tension, does it start just not working, or do you not have information on that end yet?
I don't know the specifics about that. And really in the United States, the CLIP procedure has been FDA approved just for 3 years, essentially. So the registry is helping to compile all of that data from a US standpoint, but
or if they needed repeat, like say if it's young, typically they've been an older population,
yes. We've
but
done a
like
couple,
if
maybe
it was
in their
somebody like
50s.
50 and they did it, and then they're gonna make their 15-year probably.
Sure, and usually when it is done in that patient population, it's that they either came in acutely ill, and at that moment in time they were too high risk to have an open heart surgery, but you get them through that acute phase, and perhaps they will be a candidate for a conventional surgery down the line, which would be the more durable option. Or the other scenario is they just have so many comorbidities at 50 that they really are not a surgical candidate, and the likelihood is the device will probably outlast their longevity. But we've thought about it in both ways.
Because would it have to be surgical? Say they get after say if the device starts and they need something.
We potentially
Or
we would
can you-
look at whether we could, if there was room to put in another clip.
Right.
That would not be unreasonable. And it's really just that the orifice is large enough that we haven't reduced the size too much to induce MS. And we're even, have been referred several patients who have had the opposite, have had prior annuloplasty rings placed, and they've developed recurrent MR. Is this a patient that could benefit from clip therapy? And the true restriction on that too is, has the annuloplasty ring reduced the orifice too much that already we would risk developing mitral stenosis?
Have they done any of those?
We have not.
Okay.
We have someone who we're presently evaluating who we think is going to be a good candidate for it. But so far the people who haven't have screened out because they have not had the annulus size to accommodate. So left atrial appendage closure we'll run through pretty briefly, but we will start to see this more and more. Right now it will still be limited to about 6 procedures a month, but there is quite a prevalence of atrial fibrillation in the United States. And when we look at patients who have had stroke with atrial fibrillation, 90% of the patients have had stroke related to a thrombus from the left atrial appendage. So that's where the focus on this procedure developed. And this procedure is really all about risks and benefits. This isn't somebody who's been progressively ill, who like a mitral valve repair. This is somebody who has a risk of stroke, and you're trying to balance that against the risk of bleeding. So we do calculations to figure that out. As you know, there are pharmacologic treatments, and those continue to stay the standard of care. For the patient who can tolerate anticoagulation, that's still the appropriate form of therapy. In patients who may be undergoing other cardiac surgeries, sometimes you'll see left atrial appendage closure performed with excision or exclusion of the left atrial appendage, but there is no randomized clinical data to support that truly is effective. And now there have been many studies to show that the Watchman device with percutaneous left atrial appendage is equally effective to Coumadin, but has an upfront risk because it's a procedure, and so this is an investment in the future for the patient. And the significant difference between the arms really came to fruition at about 6 months after procedure. So we do have an FDA approval now for Watchman, and that is going to be best suited for the patients who are high risk to remain on anticoagulation for long term. So somebody who has a fall risk, somebody who might have recurrent GI bleeds, someone who might be on dual antiplatelet therapy because they just had a drug-eluting stent and now you're having to think about Coumadin, but that they don't have a contraindication to anticoagulation because they will have to be on it for a short period of time after the procedure. So this is an animation of the Watchman device and procedure. This is done with about a 14 French catheter through venous access and transeptal crossing. So everybody has a left atrial appendage, everybody's size is different. We screen with TE or CT
prior to implant to make sure anatomically they have a left atrial appendage that is suitable for the device. We'll even show you some more characteristics of the left atrial appendage. And these are unexpected names for the left atrial appendage, but surprisingly, you will see them potentially on the echoes that are read as helping the physicians understand the anatomy to expect. So there are a couple different sizes of Watchman. Most of the procedure is spent just finding the appropriate size device for their appendage. And interestingly, the size of the appendage varies somewhat based on the hydration status of the patient. So, sometimes we've predicted by TEE what we thought their size was going to be, and we get into the procedure and they're just hydrated differently on that day and get some different sizing.
Well, that makes it complicated, right?
So this procedure is done with fluoroscopy and TEE guidance. And in about equal amounts. So for patients who have severe chronic kidney disease, a risky option for them. So over time, this is just going to epithelialize, and any communication with the left atrial appendage is going to be stopped. So these patients, some patients come to us on anticoagulation and their physicians think we just can't continue this long term. Some come, they've tried anticoagulation, it's not something they want to continue long term, and presently they're off of it. But the ones who are on it, we would have them hold either Coumadin or NOACs beforehand, but start Coumadin the night before. And the reason that we've decided to just transition anyone, even regardless of what they were on before, to Coumadin is that that's what the clinical trials did. And so we have evidence that Coumadin is effective in that time frame, and we just don't have that evidence for NOACs. We would expect that they're in the hospital for about a day, leaving on post-op day 1. And the patients who have stayed longer have tended to stay for things unrelated to their procedure, but they had urinary retention or they developed atrial fibrillation with rapid ventricular response and just needed some additional therapy as an inpatient. We typically see the patients back 1 week, and they are discharged on Coumadin, which is probably one of the most important things to ensure. They would get an assessment with TEE at 6 weeks after the procedure to ensure that that area has sealed completely, and if we're pleased with that result, then we would transition them from aspirin and Coumadin to aspirin and Plavix, and that's continued for 6 months post-procedurally, and then at 6 months they transition to just aspirin indefinitely.
So if they have a leak, do they stay on Coumadin? That's the way
Yes,
that
and it would
works.
probably be re-looked at in like another 6 weeks or so with TEE.
So right now they just watch and hope it stops. Is there a way to, if they had to try and fix a leak yet? Or
No, and there's
just-
not a
they're
way
just
to
not doing
fix
that.
it.
Okay.
It would be that a suboptimal result was achieved, and unfortunately
So that's
they would
not-
continue on. Yeah.
Okay.
Or someone thinks the whole reason they were referred in the first place is they're too high risk to continue aspirin or to continue Coumadin indefinitely,
Mhm.
and you will accept that it wasn't a perfect result and still stay off of Coumadin.
How many leaks have we had?
We have had one clinically significant one. I think there's a marker of like 6 millimeters as to what's considered
You'd have to
significant versus
stay on
insignificant. Right.
The Coumadin?
And we had a patient who was 7 millimeters.
I guess you don't really know, what more risk does 7 millimeters mean than 6 millimeters?
And they think the hydration issue
Could be related.
plays into that?
It could be.
Yeah.
And that, our suspicion is that it wasn't that, because we compared that patient actually back to their TE intra-procedurally, and there was no evidence of leak then. So that was one theory, was their hydration status playing a role in the size we picked versus, their baseline. But there is a possibility for, even under the best circumstances and in the clinical trials, that a leak persists, so.
Do you know how many people have had, like, what symptoms might we see after, like chest pain?
Yep. So the most common risks and complications are still low in the range of 3%, but the most probably common things to keep an eye out for would be the pericardial effusion or tamponade, and stroke or TIA.
Endocarditis symptoms with either of these?
Theoretically, you could develop endocarditis with either,
Yeah.
I suppose, but not at increased risk of endocarditis. With both, they do recommend that at least for 6 months after implant that you're treated with antibiotic prophylaxis, like with dental cleanings and things, and then that's left to kind of physician discretion thereafter. And
What doctors are doing this?
Dr. Holzhauser and Dr. Rinaldi. And then just other
And
things.
is it Dr. Downey and Dr. Rinaldi with the clip?
Dr. Downey does a select few right now. The idea is to keep, with the volume that we have, is to keep, a specialized, somebody who's highly trained and specialized in it. If the volume would substantially increase Dr. Downey would be the one to do additional procedures also, but primarily Dr. Rinaldi is doing clips, and then Holzhauser and Rinaldi for Watchman. So you may see, I think all of our patients so far have come out with femstops, but up after about 6 hours with good hemostasis, and all patients leaving on Coumadin, which will be restarted on post-op day 0 too.
So are they all gonna, and they're predominantly gonna all come out to us now too, the Watchman?
Watchman's all will, yes.
Okay.
Yep. And clip, they'll, be triaging, but probably the majority of patients would come.
So the stable ones will come to Holding, the unstable ones will go to Dixon, but they all end up on your unit.
Exactly.
Okay.
Any other questions?
Did a great job. I do have a question, but I'm